Check one. Check one.
şey şeydi Recep diye.
Hello, 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 hello. Check. Check. Check one. Check one. Check one.
الطهرة كام راترو؟
Check one. Check one.
يا شو تيتي بهنا ما تيتي مش عين يرون تيو.
Check one. Check one. Check one. Check one.
अगर आपके साथ में ड्रिंक ड्राउन के लिए चेन ऐसे नहीं होगी और देखिए कैसा ये भी बहुत अच्छा है बेल्ट हाँ ये स्टैंडर्ड है बस ये इंसान वेयर यूज करता है उसका बड़े बड़े तो मतलब आपको कोट नहीं किसी ये सब वो है ना अगर किसी की और उसके अनुसार क्या और मुझे
GMS का चौड़ा दूर जाएगा वही क्यों होता है ऑफ कर दो ये क्या है और अलग होगा ना सब फाइबर ये थोड़ी ये बनेगी या सब इधर ये उधर डाल सकते हैं पाँच डाल दे हाँ 5 पैड डाल दिए हेलो हेलो अच्छा वो रखना है यार चॉक वो का थी चॉक चॉक ड्राई फ्रूट कितने बना लास्ट टाइम चलो आप ही एक्शन हाँ लास्ट टाइम बाउल दे आज का पोस्ट अप से दे okay table chair is set moment bukeydin moment almak şu an bu sefer şöyle yapkan bittin kanaktan çogul
So needed with my mother.
akşam algun gelis bütün kumaras nasıl sanıyor Google moment algun çaldı
Kal coding exam.
çaldı
So golden arches. Shawls and children.
water lighting pad 10 pad light figure is
Shawls.
water side
Alak şey.
Mehmet Akan that is special show special show
Aynen.
yeah thank you
Sir,
हेलो हेलो हेलो
ऐसे 12 का बना हुआ है।
और लक्ष्मी ऑलरेडी मेरा
अच्छा خلاص تقول انت ويني كاكا انا طلعنا ندير كافي الو الو تيك الو الو تيك
Check one. Check one. Check one. Nasıl? Hello. Nasıl? हाँ done. हाँ चल रही है तो ऑन है तो मैं एक से बड़ा किधर हूँ मैं इधर मैं इधर हेलो डॉक्टर मंजूर वैसे सलाम अलैकुम सर you are already here yes sir actually video sir can you okay sir okay fine so shortly we will be starting okay sir so this I just got small okay sir so yes so that's shortly yes
good check hello hello check hello हाँ Rishabh, what is the status? Come on the cam. Tell someone to speak to me from OT2. Yeah, who is there? Someone sir is there?
check one check one check
OT2. Hello. Hello OT2. Sir, Assalamu alaikum. Hello. Hello OT2. Hello OT2. हाँ मगू सर. हेलो OT2. हाँ ठीक है. अच्छा कर सामने. चल. हेलो सामने सर. सर फोन कर रहा हूँ आपको सर. हाँ सर बनी. सो करो यूरोलॉजी थिएटर पे ना basically सोवरी पे अच्छु करो जो मिनी मिनी पीस है ना तो सलीम सबस we have to relay that टी सो कर ना ना ये तो हूँ टेबल का यूज मगर इमन पे आज पे urology screen will be तो कहता मैं उसके में का माइक पर भाई ये उसे चेक करो हाँ मकर माइक पर हाँ हाँ हेलो सर someone sir hello someone sir can you hear me okay sir so what is the first case sir yes thank you sir what is the first case posted sir
Take one. Take one, sir.
हेलो हेलो हाँ मंगू सर हेलो ठीक ठीक ऑर्डर ठीक हाँ थैंक यू
Take one. Take one. City Rangers. Two. 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 Take one. 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 So, because
Large myself what am I
awkward.
हेलो हेलो फोन खो दो हाँ
Took. Check one.
बहुत जल्दी फोन चेयर बोले यार no मत है वाला खाई थी भाई
Io che penso come sarà sì, ma lo strena, dunque,
वैसे हो
ठीक है हाँ
वॉल्यूम खोला स्पीकर थोड़ा Hello. Sir, video notification number 83. Hey, Theo. Thank you. नहीं मैम नहीं 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 ओके ओके सॉरी ठीक है अभी हम यहाँ से खाते हैं Check, check.
क्योंकि सर ने बोला लास्ट में
Mic. Hello, sir. Sir, you are live in the auditorium. Sir, you are live in the auditorium. Fireworks is there. So this is the firework opening. This is T1. What I think. Lesser to greater. T1 and first wall. T1 T2 junction and T2. This is papilla, major papilla. This one. This one is minor papilla and
हाँ सर मैंने आपको नंबर भेजा he will coming to pick you up you can come to pick you up इसको बोलिएगा कहाँ पे आना चाहिए इसको
D1 and D2, that D2 has hold. D1 does not hold.
अच्छा just
Yeah, and this is the institution, extra below. Did not let it facility. Fundus. And the fundus showing something here. This was a detail going one second. In that you corner. Then you have got this thing, this is a deviation here. And holding it up like a funnel. And nothing like the hair of like the no hair. So the greater curve, this is the lesion. I don't know. The lesion is, yeah.
हेलो सादत सादत बोला बाहर कितने लोग हैं सब चाय पीने एक साथ गए बाहर कितने लोग हैं वो सब चाय पीने बैठे हैं वो उनको वो अंदर लाओ ना अपने स्टूडेंट्स को लाओ ना वो क्या सब मेरा I welcome all the delegates to this second day of live operative workshop. I'll be calling chairpersons for this session one. First chairperson for the session is Professor Sadaf Ali, Head Department of Surgical Gastroenterology, Sri Kashmir Institute of Medical Sciences. She will be accompanied by Dr. Arshid Rashid, Assistant Professor, Department of Surgery, Government College Srinagar. And we are expecting two more chairpersons to join us shortly. Hello. So Dr. Ashik sir, can you please join them?
Salud, sir. The patient is all set. Hello, auditor.
Over to the chairperson. The cases lined up for today are in general surgery OT. We are going to do ETAP followed by eclasia cardia. And in urology OT, first case is going to be a partial nephrectomy and RIRS. Over to the chairperson. Hello, OT2. OT2, are we audible?
Sure. Better, you need to it will get
Are we
you to get many words of us.
Are you audible?
Hello.
Yeah, Dr. Hamid, I can see your feet, but I can't hear you.
Who is talking about it?
Yes, please increase the volume. Good morning.
Hello. How are you doing?
Good morning, Dr. Samun, and I'm Dr. Sada from SKIMS. Walaikum Salam, and great congratulations to all of you for doing very good work. Since yesterday, I'm watching it on Jakasi updates, and probably you are starting with yeah.
मेरा कैमरा आपको नहीं आएगा हाँ बस अभी जब स्टार्ट करते हैं कर क्वेश्चन करनी है आपको नहीं बोल देना नहीं को स्विच करना है क्वेश्चन तो दिखाएंगे पोर्ट से पोर्ट डालना है सर इधर ओके
You have passed the picture of you and Bhavan came on the same side in 2019. 19 years meeting, open approach or job. And he has received of level for its 20. The patient has again superated for right now we have a guy as a case of recurrent left viral hernia. So this anterior approach is already gone. So anterior space is violated. So our operating faculty will be doing a posterior approach. Most likely you'll be starting this approach and inshallah making your outcome with procedure.
Definitely. Over to the experts in this to give comments because we are into more of pancreatic surgical areas, and inshallah, you're going to do some gist and some more procedures also have understood.
Thank you, ma'am.
Okay, so let me take feedbacks from you as and when you people progress.
Okay,
Thank you, ma'am. Hello, Dr. Hamid.
hello.
Assalamu alaikum, Dr. Ashik here. Alhamdulillah, fine.
Thank you for guiding us.
Nice things going around. Hello.
Hello, yes.
Yes, I am audible to you.
Yeah, you're audible.
Yes. Nice procedure being now performed to be started. So, what is why we are doing ETF? Why not TAP only?
Actually, first approach. You have two types of approach. One is anterior approach, one is posterior approach. So So since anterior space is already violated, this patient has been subjected to anterior open section, anterior open vaginoplasty in 2019, and we don't have any deposit mesh have been used or no. Space is gone. So the only option left procedure approaches can be different. But with TAPP, also in science, you have another like complete or texture. So since both approaches and either one tap, you go into the pre-peritoneal space without entering into the peritoneal cavity. But you have to keep line in that you have on that space between PCBP like that is part of the perimeter. So the tap is bigger. You must show them. Ultimately, software so that you can get a better transition.
Okay, well taken. But why not TAPP then? What is against that?
Actually, this is the surgeon's preference. We can do TAPP, we can do TEP.
Okay.
Depends on the surgeon, with which is comfortable enough.
Dr. Samoon, Dr. Arshad here. Assalamu alaikum, sir. How are you?
Alhamdulillah, doing well.
I'm good. Please tell us about the body habitus of this patient.
Treat this patient. I am on the camera. He is an average blood person. He is not obese.
Okay.
BMI is absolutely normal. So,
Yeah, looks like the sperm cubic distance looks less than 12 centimeters.
so
Absolutely. Options for dealing with such hernias, like okay.
when you are the plate, then you go down vertical either.
Okay, thank you.
Thank you.
So when do we expect Professor Lal to join us?
Already start.
Okay.
Right here, camera.
Short position की तरफ देखो. Hello, everybody. Yeah, can we have OT1 feed? Dr. Samoon, I'll go to OT1 for the time being. Hello. Yeah, Dr. Manzoor, I can hear you. Good morning, Dr. Arshad. Good morning, Manzoor. How are you? I'm good. Yeah, please go ahead with the case profile. So, today in OT1 table 1, we are about to start a case for laparoscopic right partial nephrectomy. This is a male, 35 years the incident of finding of a right renal mass with no other significant complaint. When the CT was done, the CT showing a enhancing mass lesion of 2 centimeters at mid-pole and is predominantly atrophic more than 50%. That comes from pelvic connection system. We even did MRI to delineate the relation to the system and pre-commercial fat. That is then showing there is no relation from that place. So this patient is planned for right laparoscopic partial nephrectomy. Any questions from the audience? Yeah, could you please tell us the nephelometric score of this patient? The patient has a nephelometric score of 6. Okay, so it's an ideal case for partial. Yes. Laparoscopic partial nephrectomy. Okay, wonderful. Okay. What's the exact status this time in university? I request my cameraman to show to the patient. This is the question. So we give the same question every patient for partial nephrectomy also. Can you see the question? Yes. So, same question you just ask your cameraman to zoom in, please. Zoom in, please. Let me just try it over. So, it's not exactly the 90 degree, just go 70, 10 to 15 degree away from this. So, it's really a slightly slanting one. So, you close your ports. The sir will be showing you this in the next sir will be showing you the port placement. So, you will close your ports after creating the domain. The question of the pin placement. So, are you planning a retroperitoneal or transperitoneal? Transperitoneal partial nephrectomy. Okay, thank you. Dr. Manzoor, I will take your leave for the timing. There is a case being started in OT2. I'll get back to you. Thank you. Yeah. Can I have the audio feed from OT2?
42.
लगा के रखोगे या बंद करो?
मैम
जी सर्जन ज्वाइन करना. So I would, for the benefit of students and audiences which are a little less and yet to join, I would like if Dr. Samun would give all details as he progresses to the depth of the procedures, including exactly how do they do it. Dr. Lal would be performing it in best of the way as an example for students.
Can I have Dr. Samun from OT2? OT2 feed. Audio OT2. Audio नहीं आ रहा है मैम OT2. Hello OT2. OT2 audio is off, I guess. On कर लो. चल रहा है? OT2 audio please. Dr. Samun.
He's trying to do it.
Hello.
Yeah, Dr. Archit.
Yeah, we were not getting your audio.
Okay, then I can talk.
Actually, Sadaf ma'am had a question to you. Till Professor Lal joins us,
Okay.
could you please explain the basics of this procedure? How do you exactly proceed with ETAP?
Yeah, okay, so what?
Could you get the mic closer to your mouth, please?
Let me take. So actually, how is it different from normal therapy? Currently on what goes on? For a season, it's not not you what you call like so what is normally playing the first camera to use similarly now the things that we are southward are getting the camera original. But this is our first four camera. You know.
Yeah. Yeah, please go ahead.
So, when you understand that camera put there, what we do is we go to the left hand and throw the display first of all.
Okay.
Then we look like a smart.
Dr. Samun, hello.
Yes, Dr.
Dr. Samun, is it ipsilateral to this ipsilateral or contralateral? So so contralateral. Okay.
Yes.
Okay.
I think probably last week joined it from the theater. And I know the mic and
Please wire up, sir. Sir.
On the table.
Good morning, sir.
Good morning.
Sir, Arshad this side.
Good morning, Ansha.
Sir, how are you?
Good morning. Thank you very much. Thank you for your kind invitation to come here to GMC. It's a real pleasure.
Sir, it's always a pleasure hearing your voice from OT.
So we have this morning a 72-year-old man living one in India.
Sir.
And the planning is to do is so basically, nothing on the list. Do the thing. Nothing can do what? The word. Nothing can not be as a word. So, see next time.
Sir, we are not getting the exact feed. We are getting your image, sir. Ask the cameraman. The cameraman could focus on the patient, please. Yes, sir. Now it's clear. Right, sir. Okay, sir.
So we walk in a plane.
Sir.
You know, like, it's in beauty form, which is already over.
So, sir, you are planning an optical entry?
Then you go for an optical entry for the second dimension.
Okay, sir.
You follow the dimension.
Sir, I'm still fond of those S retractors that you have shown us how to do it.
Yeah, thank you for the
EP.
that's you for it. You know, all those reference. You for that, people can learn from the
Right, sir. Right, sir.
Yeah, good morning, Professor Lal. I'm Dr. Sadaf Ali, dominantly an open hepatobiliary pancreatic surgeon at SKIMS. And it's an honor to chair a session where you are operating with your vast skill of experience on this recurrent hernia.
Thank you very much. Thank you very much for explaining which
Not yet, sir.
You made it inside your place.
Right?
Yeah, it's there on the file.
Okay, so we're going. You can see that
Right, sir.
she was expecting a very great office.
Right, sir.
She was very happy.
Right, sir. Right, sir. Space बनवा. इसे बता. Game sport बना ना बात करो. Right, sir.
Direction.
In front of the sheet. In front of the sheet.
Definitely, sir. You are there.
Sitting there, if you want to go into the seat, seats already gone into the 52 seat. You know what I'm trying to tell you?
Right, sir.
Train, element, train now.
Yeah.
When we came to one. No, I think the mechanism to clear our machine.
Right, sir.
We can see that.
No. What should be
Not happen. Yeah, we got it.
You can see now.
Yeah, no,
Right, sir.
we have taken an area impact again.
Yes, sir.
Now I need to get it. You are ready to rest of your one, really? You can open it now. You drop the bridge and comes. And then you have over the consider kid. You are okay to leave.
Shruti, sir.
Yeah.
Has not gone beyond.
Just okay. This is which OT? Yeah, I think in OT3, are we connected to the people over there operating? Professor Salim is operating over there. The audio is not there. Professor Lal will take your leave for some time, and we'll be going to another OT where they are demonstrating a procedure on gastric cyst, laparoscopic resection of gastric cyst. Thank you very much, sir. Audio उनका भी.
I want audio OT3, please. Yeah.
Yeah. Hi, Rifat. Assalamualaikum. Walaikum. Good morning. Yeah, hello, you're audible. Please go on. We are eagerly waiting to watch Professor Iqbal Salim operating on the gist which we.
कैमरा इसमें था इसके लिए टूल लाओ
दिखा ये इसका सेरेशन दिखा हाँ चलो बीच ये राइट साइड लिवर इधर काटो ये 5 mm और काटो और काटो
Yeah.
छोड़ो
Okay, report fine. Yeah, we watched that endoscopy also. So can you just share the pictures of your CT scan and then hand it over to the operating surgeon to give details of ports and all placement.
इसमें सेरेशन नहीं है दे दो टूथ वाला
It can be zoomed little bit. Yeah, we really appreciate it. Now it's almost on the body of the stomach. Yeah.
एक मिनट में नीचे के लिए
Yeah, Assalamu alaikum, Dr. Iqbal Salim. Good, I am good. First of all, let me congratulate you and the whole team, Dr. Professor Mufti, putting up a wonderful show today.
ये क्या शो
As coming to your case, you know that with increasing imaging and good quality work from radiology side, we happen to pick up even asymptomatic small lesions like just. So please let the audiences get enlightened with the details of procedure. How did you put the port and what are your plans? Yeah. Okay, fine. So
Iqbal sir, good morning. Sir, we won't take your leave for the timing because Dr. Lam is about to put the ports for ETAP. He will show the port configuration. Can I have OT2? Can I have OT2 audio? OT2 audio, please. Yes, sir. Oh, sir. Thank you, sir. Can we go to OT1, please?
Yes, OT1 here. Good morning.
OT1, hello.
Good morning.
Good morning, sir. Dr. Arshad here.
Hello, Arshad. How are you?
I am good, sir. Unfortunately, we don't have the company of urologists this time, sir. You will have to bear with us.
No issue.
I think you should be describing your procedure, Dr. Saab, so that the audiences are, updated. We have some 5-7 minutes with you in the OT till when other twos are going ahead with their basics of procedure. So you have started dissecting?
Welcome, Sadaf. I'm planning to do a partial nephrectomy on right side.
Yeah.
I have 3-4 ports this time. One is for retracting the liver. This is the 4th port. I still to adjust it because there were some adhesions here. And 2 others. One is working, 2 working, and 1 camera port. My right side is a working port is 10 mm, left side is a 5 mm port, and we have a 10 mm supra umbilical camera port.
So if you are transperitoneal, you need to reflect the colon and all those
Yes.
down. You have to
So,
take care of your liver.
Essentially, the first step is this is the kidney,
Yeah.
and this is the colon. So first is to mobilize the colon and expose the gerotas, and then we proceed to identify the hilum. So as we go on, I'll keep on explaining to you. This is basically a lower pole tumor, which is around 2.5 centimeters, very small tumor, and by all means, an indication for doing a nephron sparing surgery. And we are contemplating doing a wedge resection of the lower pole tumor and then doing rhinorrhaphy. So this is, let me adjust my first retractor of the liver. So I have a very dynamic team with me. My cameraman is my registrar, Dr. Jaiparam, son of a urologist, so I don't have to worry.
Okay.
And,
Very good.
and then I have two upcoming lady surgeons. I'm sure they'll make a mark at their own time.
Definitely.
Dr. Adan and Dr. Sabia.
Okay, good.
And,
Great.
we have of late a shift from male to female side in surgery, and that's a good trend. And it has been my endeavor to expose these residents, PGs, to all kinds of procedures, whether it is plastic, pediatric surgery, even I send them to neurosurgery, urology, of course, and then general surgery. And they are making a wonderful team for this workshop. I'm highly thankful to all the people who have worked day in and day night to make this. It's not easy to conduct an operative workshop.
Yeah, definitely.
And
I had some suggestions if this could have been coordinated in of halls, then audience would have focused exclusively on one procedure at a time, because these are the nephron sparing, partial nephrectomies.
I have fortunately a diverse group of audience.
Yeah.
It's a portfolio of general surgeons, pediatric surgeons, and urologists,
Urologist, yeah.
and of course the postgraduates who have to know all specialties at this time of training. It's part of it. The idea here is to expose them to various specialties.
Sir, sorry to interrupt you.
For audiences, what would be your potential indications of sparing procedures, like borderline malignant lesion, like what we go for conservative surgeries in our subset of patients? So,
Well, there is a definite scoring system for
so we have decided.
so devising that plan,
Yeah.
which indicates whether it's a polar lesion, size of the lesion, how close it is to the hilum, and whether it is central tumor. So all these parameters are taken into considerations when you plan a nephron sparing surgery.
Okay. So they are planning to go to the.
Sir, I'll take your leave this time. Professor Lal is putting in the ports for ETEP. I'll get back to you, sir.
Please do, please do.
Thank you so much. Can I have OT2 audio, please? 52. Sir,
You are pointed, standard by pain on the left side.
yes, sir.
That is the important segment in there. You also go and the existing dialogue fine.
Triple down, sir. Triple down, full down.
Try, then from left four, that's not good. Which can be clearly abdominal wall. Yeah, this is nice.
Absolutely, sir.
Good. This is good. We teach here. Make sure you keep it, take it off. Take it off, make it see it, higher. Higher is that. Yeah, fine.
Sir.
And then you have to make it clear, right? Because that's the only later. Also, you can see you can switch screen, right? So you can have a picture, you can have some, you can have a
Sir.
so if you want to go, like, have you, already like how my thing.
And the view, sir.
So, you can like you, this, you can learn,
Right, sir.
you can hear, you know, you all know that.
I know, sir.
You know, you're 30 degrees, you get a little bit more space, you can see what's going to the opposite.
So it's a major recurrence, sir.
I can't hear you.
Well, you need to, then,
Abhini,
then you talk to the crowd.
कर दो.
Right, sir. Right, sir.
So you cannot all into the party where you can all the other one is छोटा कॉम्प्लेक्स भी बनाते हैं तो रिपोर्ट के लिए रिपोर्ट में ड्राइव बनाओ ठीक है रिपोर्ट और डॉट Hello, 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 Dr. Lal, Dr. Ashik from auditorium. Hello. Hello. Yes, you are audible, sir. I would like to know what are the pressures this time. For the general laparoscopy, we keep 14, 15 mm of mercury. What in the TEP and X, this E-tap, what are the pressures? Yes. Sir. We don't keep it beyond 14, 15 in E-tap. Sir, if we keep the pressures on the higher side, maybe 20 or more than 20 for the E-tap, probably that will. Oh.
Sir, would you prefer a sharper dissection there, or you will still go ahead with the blunt split?
Exactly, sir. Right, sir. But sir, that is the advantage of ETAP, that it hardly seems to bother you, the pneumo that is created.
कैमरा जरा टेढ़ा हो रहा है भैया, तो कैमरा सीधा रखा, हाँ ऐसे नहीं, वो नहीं, इसमें साइड ही चेंज करना होता है. इट शुड बी पैरेलल, दिस इट शुड कम इन पैरेलल. You don't have to go along the aligned organ.
With the permission of the chairperson, I have a small announcement to make. We are being joined by Dr. Rashid Sheikh. He is a program director, HPB Surgery, Keck School of Medicine, University of California. He is a graduate from this place. I request Rashid sir to kindly join the chairpersons.
Welcome, Dr. Rashid. And there have been lots said about him coming to Valley and demonstrating robotic surgery. So I welcome him on behalf of all chairpersons, and hand over the mic if he would like to make some comments and intro.
Actually, thank you all for having me here. It's a pleasure. I last time was here in 2004 when I was intern, and now 20 years forwards, I'm back here. It feels very nice. This auditorium was not like this, but it's great to be here. I hope I can share something with you guys tomorrow and learn from you guys as well. Thank you.
Welcome, Dr. Rashid. I have been 2 years junior to you. It was always a pleasure working with you.
Yeah. Yes, so Professor Iqbal, am I audible to you?
Hello.
Hello, can you connect the audio to the OTP?
Hello.
Can I have audio thing OT3?
हमारे अर्शद नहीं है लिया वाला,
Yes, sir.
उसको बोलो अभी हम RRS चालू करेंगे, 2 मिनट हमको देना, ऑडियो हमको पेशेंट देखो. एक्सटर्नल कैमरा उस पे फोकस करना है, फोकस ऑन दिस.
Hello.
Secret. हाँ.
Professor Edwan? Huh?
आप लोग तैयार ना?
You can see that you can see that so you can see that I'm going to yeah.
उसी का एक्सप्लेन कर दो, पूरी करना एक्सप्लेन. माइक अच्छा, चलो क्या इसके स्टोन डायमेंशंस
ठीक है, ये क्या है?
क्या इसका 1500. Yes, that's chill. So, where is it? चलो बेटा निकालो उसका, बोला बात करता हूँ, बाद में बात. chill.
Can we have audio?
ये क्या है?
किशोर ये सारा मिनट खड़ा है.
ये It should be on right side, which is not on left side.
Only two, please.
Good now.
Yeah. This is very now just that's what exactly problem
What's the camera? Yeah, खुद से दिखा दूंगा.
to you. Yeah, for you said you will be
चलो छोड़ दो, मुझे नहीं चाहिए.
reached
Relax, just like. क्या साइज है स्कोप का? ये कौन सा साइज है यूट्रोस्कोप का? चलो फोर से दे दो. No Olympus scope, sir. You can compare the. तो मैं एक्सेल शीट खोल दो.
we can have comment supply of whereas and now. Professor, instead of
तुम्हें गाइड करने को हाइड्रोफिलिक.
sir, can we avoid the interior gastric wall with the structures that we bring the gas in the yeah. Switching.
Stop it.
Just
Yeah.
that makes
Stop it. Maybe. चलो सर.
Why we got on the air to leak?
इनका ही है. वो हमने पूछी थी. Where was it? You put her opposite to us.
Please put the right to ground. Meanwhile, if you get your bearings right,
ए भाई ओटी वन शायद कि चला कि नहीं.
okay, two. Audio from where
चलो खुश. मेरी बात बुरा नहीं है तुम. मैं सीखा क्या है? तुम्हें कहाँ दिखाना है? मैं क्या डाल रहा हूँ? हाँ? मैं कहाँ डाल रहा हूँ? तो मुझे कहाँ देखना है? मेरे कुराना मुझे कहाँ देखनी है? तुम क्या हो गया? थोड़ा कैसे कहा? अभी नहीं. माइक लगा क्या मुझे? चलो चलो. बैठा 2 मिनट आ. चलो. अब नहीं देना मेरा प्लेट है. अब नहीं चाहिए मुझे. क्या बात है इसकी? रखो क्या निकालना है? शुरू तुम ये उसी रखे उनके हाथ में रखा पी कर. चार शिफ्ट बस. वहां से नहीं जा रहा. आराम से आराम से आराम से आराम से. मैंने अपने तो छुपा कर इसी बॉडी से चला.
yes, sir.
Right, sir. Right, sir. Right, sir. Right, sir.
Asking my beliefs.
Right, sir.
Procedure but completed for a live workshop.
So we will appreciate it. The space, it's almost like a football play field. We'll going to go to UT sir, meanwhile. Thank you, sir. Thank you, sir. OT1 audio.
OT1 here. Yes.
Can we have the audio of the case that is being shown on the screen?
Well, this is a partial nephrectomy case. Is that what you mean?
I don't think so, sir. We are getting the feed of partial nephrectomy video, sir. We are getting the CT scan showing a stone, as I can see, sir.
That is the other OT. That is the other table in OT1.
Right, sir. I want that.
छोड़ना इसको यार वर्कशॉप में अपना काम करना केस या
Can you hear me?
very much clearly, sir. Am I audible?
Yeah.
You can see there is a left side of pelvic calculus,
Okay.
and this is a 15 mm calculus,
Right.
and the Hornsfield units is the 1500. We are planning to do an RIRS in this patient.
Okay.
The accessory which we are using the blue neem access sheath and the guide wires. And a digital uteroscope we are using that is from Olympus V3. This is one of the best scopes which you have available currently. And we'll be using the Holmium YAG laser 30 watts for this procedure. Okay?
Okay, sir.
Okay.
When are you starting the case, sir?
Boss, I am just to start. You are getting some endovision or you are not getting?
No, but we are getting the
Okay, shortly you will get the endovision also. Are you able to see the endovision?
Yes, we have the video now.
Now it's a stone actually. This is a bifield polycalcium system and this is the junction of the upper and the middle moiety. So we'll be shortly starting the procedure. Doctor, I want apnea. अभी नहीं आप इसको दे.
So now we will take a link for a scene.
Yeah, please.
We'll go. Professor Lau.
छोड़. आराम से करना होता है. Relax.
Spirit.
Focus on your next step, what you are doing. Don't get distracted things around you. You think you are only remaining 2% in the food. ठीक है? Distraction, down. Relax. Tension नहीं लेने का. I'll listen to you.
Yes, sir. Suno, sir.
No one is better than you. Start believing in yourself. You'll listen to Chalo ji, give me the fiber.
This is operation. It's you're from some creative arrangements. Creative and some possible.
So सीट का लेवल का तैयार रखो.
For absent, please. Absent. Take the shift. Put it on.
Right, sir. We can see it, sir. The earlier got reduced, but. Right, sir.
Fragmentation settings.
नाम करो उसको 0.6 और 8 कर दो. 0.6 जूल 8 हर्ट्ज.
Every day करना है.
Dr. Lauren,
Every day करना है.
when started the procedure, we were anterior to this something like a sheet. Isn't it? So when we consider this in proper session, I want to find it. Sir, sir, but we once we started it, we entered anterior to the
Pilots.
ना ठीक है.
Ready.
अब जैसे वीडियो कौन सा चल रहा है, यूट्यूब पे कौन सा चल रहा है, बात चल करो. सब छोड़ इनके पकड़ को तुमको. हाँ आप छोड़ हल्का हल्का एजुकेशन कर रहे हैं. डॉक्टर साहब आप लोग प्लीज करो एजुकेशन. ये हवा कहाँ से आ रही है?
We are like endo as well as body.
And someone is talking.
Right, sir.
हवा नहीं अंदर चाहिए मतलब. ये मॉनिटर ना इसको मेरी तरफ रखो. मॉनिटर प्लीज जा सकते हो. .8 joules.
Right, sir.
Said the paper on the
कुछ नहीं कर क्या कर रहा है, क्या दबा रहा है इसको जैसे कुछ काम कर रहा है.
Yes, sir.
You don't have to make it a point that it should be excellent vision. Well, sometimes it should be very good vision. The irrigation which you use for an excellent vision actually increase the pressure in the kidney. थोड़ा सा दिखाओ एज पे चल रहे हैं ना. ध्यान से चलना, लेजर पे नहीं तोड़ना वो मैं इस टाइम.
That's what you're ventilating. What is the EtCO2?
Certainly. Certainly.
Yeah. CR.
One audio, please.
Yeah, Dr. Arshid.
Dr. Ahmed,
Yeah.
please go ahead.
Yeah, the video is on. You are seeing the irrigation. You are using, actually, we are using the laser dusting settings. My settings are 0.8 joules and 8 hertz. Dr. Arshid?
Sir. Yes. Dusting it, could we get the video feed from the partial nephrectomy that's being
Yeah, why not? Partial nephrectomy का वीडियो रखो वहाँ पे.
Partial nephrectomy feed, please. Hello.
Oh.
Can we have Mufti sir's vision? OT1?
Yes, OT1.
Sir, please describe where you have reached. You seem to have mobilized the kidney.
Well, let me go back. This is, can you zoom out thoda? This is the IVC here. Can you see?
Right, sir.
And this is the ureter.
Yeah.
And we have gone into the retroperitoneum, and this is the psoas muscle. You can see iliopsoas. This is posteriorly. I have removed the Gerota's fascia, and now I am going to this area where I anticipate the hilum to be. We'll delineate the vessels and artery and vein, and then mobilize it from above and laterally, and then we'll turn it this way because the tumor is somewhere here. Is that clear?
Right, sir. Sir, with your permission, we'd like to go to OT2 because Professor Lal is putting in the mesh there and he's about to complete his case. So we'll get back to you, sir.
No issue, no issue. Go ahead.
Thank you, sir. OT2, please. Yeah. Sir.
One.
Right, sir.
Now you can see six. And from again from
Right, sir.
I want this suction tip. Camera ठीक है. Go in.
मैं शोल्डर from three to plus maybe and you go through the 12 camera phone, camera back in, push from the
No, sir, we are here, sir.
Okay.
We are here with you, sir. Right, sir.
So you did so much way that I can play about this match. Hopefully you're trying to think of only and I see
Right, sir.
that you the year.
Gauze किधर गया? दे दे.
Oh, please, sir. There is a question from audience, sir. Right, sir. There is a question from audience.
Sir, this is Akhtar Ganai from Jalan Hospital. Sir, Jalan Hospital, sir. Jawaharlal Nehru Memorial Hospital. Sir, what do you do with this pseudo sac or a reverse sac? Would you like
Go
to
in.
suture it or
I don't want to
right, sir?
yeah.
So,
And we will have up on
right, sir.
the
So, what is your experience about distal sac seromas?
I
It's a humbling series, sir.
so when talk about no I remember 12% remember today that making
Right, sir. Right, sir. Right, sir.
So you see
Structures. Yeah, it's
It is, sir. It is.
structures. Yeah.
So, sir, Metronics people have to work on it.
no. Take one with it. That's why I think what you're doing. One man, that even with bomb here. You know that with bomb? Bomb here.
Right, right, sir.
So, so again, but coming
Okay, sir.
Okay, let's go in.
not here. Now, as soon as I take it down, you will find that I, well, it was visible earlier, has changed. Changed.
Right, sir.
Now, and bringing on now, what?
Right, sir.
So, we will be over, it will be camera, it will be engine.
Those new cameras.
Absolutely, sir. I know, sir. 30 degree. Right, sir. Right, sir. No, sir.
Was wonderfully demonstrated.
Sir, everyone is in awe and you can hear the applause, sir.
All orifices are properly fixed.
पीछे इधर इधर नीचे मैडम के पास
Right, sir.
Okay.
Right, sir.
Right. Very good. Excellent. Very nice. Sir. Very nice. Thank you, sir. I think the organizers are saying that Professor Senthilnathan is available for OT3 surgery where they are planning a distal pancreatectomy.
Can we have
Can we have the audio visual of OT3 in a more appropriate way so that somebody coordinates with us from the other end?
Can we have the feed from the GEM Chennai? Can we have that feed?
Yeah, there. Yeah.
दे दो ये
How
suction
big is
tip.
the lesion on imaging? This is Dr. Sadaf here, Dr. Senthilnathan from SKIMS Srinagar. Hi. Can we have some details about the size of the lesion and of course this subset of patient I would opt for a splenectomy as well.
Because
With the permission of chairpersons, we come to the end of this first session. I request Professor Sadapali and Dr. Rashid to be seated as chairpersons because the robotic session is going to continue. And we would like to felicitate our chairpersons of first session,
Dr. Ashik, and I request Professor Nasir Awan sir to come on the dais to felicitate our chairpersons. Dr. Ashik sir, please. Dr. Arshid Rashid. Dr. Arshid. I request Professor Ejaz, Head Department General Surgery, Skill Medical College to join the chairpersons. Professor Mubashir Shah, Professor Department of Surgery, SKIMS Sora. Dr. Shakib Nabi from the Government College Baramulla to kindly join the chairpersons.
No.
Can we go back to
What are the chairpersons?
can we go back to the GEM team being projected probably from the system of OT3? Yeah, sorry for the interruption, Dr. Senthilnathan. Can you continue with the demonstration? Right. Stomach as well. Okay. Right.
Go ahead.
Large pancreatic lesion in 19-year has to be a spen only. So, yeah, with some peculiar features on imaging. Right.
Go ahead.
Okay. One dissect.
Go in.
Okay.
Hello. Hello. Yeah, this
Yes.
is Dr. Mubashir from SKIMS. Do you always choose splenectomy along with pancreatectomy in span, or is the size of the tumor, or there are some characteristics that will decide for the splenectomy also?
Go in.
Right. Thank you.
Rekha. Over here.
Dr. Nathan will be back to you after a while. Just we are going to OT1. Is OT1 connected? Dr. Javed?
Yeah.
Yeah, please. Yeah, you are doing a perfect, beautiful dissection. I think it's possible that correct me if I done. We said I'm Dr. Ajaz. With me, Dr. Sadam and Dr. Mubashir. We have
Sir, actually, partial vasectomy, Dr. Mufti sir is doing.
Okay, okay.
I am doing the RRS.
Yeah, you want to see Dr. Mufti doing what he has done so far. Can we connect Dr. Mufti?
Irrigation both.
OT1, is it OT1 Dr. Mufti is operating? Yes, Dr. Mufti. Assalamu alaikum. We are here with you. Yes, please go ahead and tell us where you have reached. You are not audible. Dr. Mufti, please adjust your mic.
Mic, please adjust my mic.
You are audible now, sir.
Yeah. Please go ahead and let us know where you have reached so far.
So I am in the process of mobilizing the kidney because we need to mobilize it on all sides. Plus, we need to have the hilum skeletonized
Yeah.
because we have to go around the hilum. We have to clamp the hilum while we are resecting the lesion on the lower pole. So this you can see, this is the psoas muscle. This is the ureter. These are the hilar vessels, the vein and the artery. This is the upper pole I have mobilized. Can you see the upper pole?
Yes.
Yeah.
Upper pole I have mobilized. I am going inside. You see, I can lift the hilum here. I can even go around the hilum.
Perfect control over there.
Yeah. And now I have to do lateral mobilization. This is adherent to the parietes. I am in the process of
Right.
freeing it from the side wall. So once the kidney is mobilized, then I have I can turn it around I can bring it to any direction, depending upon the convenience of suturing and resection. The tumor is somewhere on the lower pole of the kidney. I have yet to remove the gerotas on this side.
Right, right. Would you like to use slash and ice for that, or you don't after controlling the renal pedicle, or you don't need in partial nephrectomy?
Well, this is a short procedure, a small tumor.
Right.
So we can do it in a recommended half an hour period of warm ischemia, with a 20 minutes to 30 minutes warm ischemia.
Right.
But if we anticipate that the time may overshoot, then we have an option of using the ice slush also.
Right. For the sake of postgraduates, is there any other method besides this to have the perfusion? Any drug used for that?
Sorry?
Any drug used for? I think inosine was the drug previously being used. I don't know. Is it being used today? These days?
Well, we are commonly using a cool environment around the kidney, breaking the ice into small ice slush and surrounding it as they do it in the transplant.
Right. It's an advanced procedure to do a partial nephrectomy. Is an uphill task, and Professor Mahmood has mastered the technique, and his young urologist, Dr. Said Javed Qadri, is also doing. And I have seen in many workshops, live workshops, they are doing a commendable job.
In the meantime, can we go back to GEM? They opened the gastrocolic ligament and I think tumor is visible now.
Yeah. Yes, Dr. Senthilnathan, I think they're connecting to you. Are you with us? Not yet. Yeah, we can hear you. A little volume issue. Can we increase the volume? Yeah. So we see that you have exposed the lesion. Yeah, you are audible now. Perfectly.
Dr. Guys, मैडम ये जुल्म नहीं करो हमारे साथ.
You speak.
Dr. Ijaz?
Yes, right.
Dr. Ijaz Rathir?
Yes, please. Excuse me, Dr. Sentinel, just we are going to OT1. Just there is something there to. Yeah,
Doctor-
yes, Dr. Javed.
Yeah. We almost issued the bulk of the stone. You can compare this laser fiber with the stone and see what the size.
Right.
So initially the stone was in the pelvis
Yeah, fine.
and we have now pushed it into the superior calyx. So there will be controlled fragmentation and dusting of the stone.
Right, wonderful.
Right.
Sir, any queries from the audience?
No, you are doing excellent job, and let us see if there are any queries and comments.
Just to revise the things, this patient had a 15 mm calculus in the pelvis and we had stented this patient 2 weeks back and the plan was to do RIRS. So today we have taken up this patient. We are using the audio visual from Olympus
and the accessories from the blue neem.
May we know the contraindication to RIS for the sake of postgraduate?
The contraindication is first one if there is active UTI going on, because this is a procedure which has maximum chances for post-operative fever and other complications. Additionally, if there is something wrong in the drainage pathway of a kidney, for example, if there is a stone and here is some maybe a purity obstruction, so at that time we don't have to fragment it because all this fragment will remain in the kidney. So all those situations where outflow tract is in question, you should not do a RRS. You should always puncture and do a perk and remove the stone by a PCNL. Primarily, we are doing this RRS up to a stone size of 15 mm, sir.
Sir, this is Dr. Shakib speaking.
Yeah.
Good
Good morning, dear.
Yes, sir. Good morning, honorable now. Sir, just for the sake of the postgraduates and the residents here, how do you select your patients for this was a pelvic stone? That's
Yeah.
what I heard. So how do you select your patients for PCL and your patients for RS? How do you determine which patients?
Number one is the stone size criteria. We always try to remove a stone without puncturing the kidney. So if the stone size is up to 15 mm, we prefer to do a RRS and not a PCNL. Now, if there are multiple stones, all calyces, they are partial stag horn, or the stone size is 3 cm, 4 cm, we always do a PCNL. And understanding if the calyceal anatomy is such that our flexible uterus scope will not reach. For example, there is an inferior calyceal stone with acute angulation and large stone. In those scenarios, we always do a PCNL and remove the stone. The rest, all stones less than 15 mm, the first take should be an RRS.
Okay, thank you very much. Nice to see you again.
Thank you, Dr. Jari.
Thank you, sir. Thank you so much.
Can we go back to the national hospital?
I'm so joyful.
You might just say a few things for our students.
Hello, can you hear me? Yeah. Hey, this is Dr. Sheikh. I'm from University of California. I'm a HPP surgeon. So can you tell us why did you choose to retract the stomach this way up? Why not put a retractor or just suture the stomach to anterior abdominal wall? It seems like pretty cumbersome. You're going through the liver and putting a hole in the liver. Can you be louder? Sorry, can you be louder? It's very volume is low. Can we increase the volume in the?
Don't you, Dr. Rashid, feel sometimes we don't need even to retract the liver, just use the stomach to retract it up and
The way I do it,
liver would
I will
require to be.
free the gastrocolic ligament and with a 2OV lock, put a stitch on the stomach and anterior abdominal wall. And the whole left lobe of liver and the
Just go
stomach is
along
out
with
of
it.
your way.
Yeah.
That's how John Martini does. That's how I do. That's all the people in the States are doing it now. Initially, when I started, I used to use a retractor, which is called Nathanson. I used to put Nathanson and retract it. But even Nathanson is also very sharp. Sometimes you can poke into the left lobe of liver and cause a hematoma. So then we devised this is a better way, just mobilize it. And I don't know why Dr. Senthil Nathan is also using a harmonic scalpel, because clearly harmonic is not a robotic instrument, even though they have the robotic, they have made it for a robot, but because it doesn't bend, so it doesn't give you advantage of the whole robotic system. Can you comment on that also? Why using harmonic, not synchro seal or not vessel sealant?
Yeah. Hey, we don't have that actually. We only have the harmonic access there.
Oh,
And
sorry.
then the harmonic has
You go in.
only yeah. But the direction of the capital was the amount of the that's all. And then you proceed with the final dissection with the four.
Harmonic.
One when taking very valid point that the harmonic it does bend in the robotic system. So that is one inherent disadvantage with that.
You know, also for the stomach, like you did, I used to do initially I used to do like I said, I used to do Nathanson and all those things. Then, you know, John Martini is a friend. I don't know whether you know John or not, Caroline. So he was like, why do you do this? Just put it up and use a 2-0 V-lock. I do the same thing. And then I started doing that, and my life got so easier. And in 2 seconds, even my fellow can do it. Mobilize the left, this gastrocolic ligament, put a 2-0 V-lock, put 2 sticks on the anti-abdominal wall, and you're done. You don't need to worry about anything else. And I'll appreciate if you can show us your port positioning also, if you have an outside camera. Thank you.
I just mentioned about the port position earlier as we had started. So the port position, one when the robotic camera is at the level of the applicators, and then the R1 and the R2 are at the level of the pitch values were matched about 8 to 10 centimeters from the camera position. And we have an assistant procar that placed below the robotic procar, about a few centimeters below that on the left side, so that the assistant can do the extraction, the clip application, and the stapler filing if necessary. We put in a 10 or 12 procar for the assistant, and as I already mentioned, we need to have a legally competent surgeon at the bedside, complement the section that we do at the console.
Yeah, I mean, that's a point well taken. Initially, when you start robotic, you really need a trained assistant. That is one of the shortcomings of robotics. You need trained like in US, we have trained surgical assists because we want the fellow and the residents to sit on the other console. And most of ORs are double consoles, because we want them to do the case. So bedside assistant has to be a trained surgical assist. And we have to send all of them to Sunnyvale to get them trained. And regarding the port side, I agree with you. I do it slightly differently. I put like a 12 robotic stapler port. And assistant port, I put an 8-year seal in case of sometime we had to put a stitch or assistant can retract the colon. And right now, can you, for the audience here, can you tell us what you're doing right now? What is the exact step here?
Yeah. We are mobilizing the aspect of the pancreas. We are retracting the colon downwards and we are delineating the intrapancreatic margin. One point shown as we can see there is that you can accidentally open up the mesocolon or the medial flexure. So you must keep that in mind when you do this mobilization. And you have to lift the pancreas sufficiently so that the colon is moved downwards and then you free of the pancreatic body and the brain. That's what we're doing now.
Yeah.
Sorry,
Much better instrument.
somebody is remembering me. For the bad reasons or the good reasons, I don't know.
And one more thing, why do you choose hook rather than a hot scissor, which can you can use as a lot of people when they start they use hook, but then when they progress in the robotic in their robotic journey, they change to hard scissors because you can use it as a cold scissors and at the same time use it like a Bowie. That's what we have. Any specific reason for you to use the hook in that, or you feel more comfortable with the hook?
Yeah. Just a matter of when take this. Just a matter of comfort that we are using it.
And have you had ever colon injuries when the colon is stuck to the tumor in your practice?
No, we've had a couple of cases where the colon was dead.
Yeah, tumor, yeah.
And maybe they were still there, but we not had inadvertent colonic injuries, which was, it was not that it was inadvertent.
Yeah.
Just a couple of two times we took very big tumor towards the infiltration where we had to separate that because of desmoplastic reactive, the colon was partially adherent to it. And we had to take a step there, but otherwise, no colonic injury. So, as the prerequisite here is to have sufficient downward traction by your assistant, so that the training section is always very comfortable here the tail of the pancreas. Do not let what is the ignorant as you go to the ultrasound here or the monopolar. You have to be very careful about.
So I see here you're trying to mobilize the inferior margin of for the purpose of for the benefit of the audience here, that you're trying to mobilize the inferior border of the pancreas so you can mobilize so the tumor can be more mobile. And then what is your next step after this? After you free it?
Part of the pancreas, which is part of the body pancreas. This being an SPD, there is no need to do or
Yeah.
Here we will be mobilizing the inferior part of the pancreas up to the body and kidney. And then you go to the part of the pancreas and start detecting for these splenic, and then you would identify the splenic artery, loop it, and then go out to the splenic vein. This is what we are planning.
We have a question from the audience here.
Professor Umar Javed is here.
Yes, Dr. Santanathan. I'm Dr. Umar from Srinagar, Kashmir. This is a wonderful procedure you are doing right now. But this is a wonderful procedure you are doing. Am I audible? The only thing is that as far as the robotics go, robotics is still in infancy, especially in our part of world. Laparoscopy is moving fast, but didn't get time for laparoscopy work. But the youngsters here, younger than us with age, of course they are professors. They are doing fantastic job. And I have been a witness to many laparoscopic procedures here in this institution. What I want to say is, as far as the robotics go, what do you think the advantage vis-a-vis the laparoscope it is? And any advantage of the open? Because I have been a student of this organ for a long time, almost 30 odd years. I still believe that oncological, I'm talking about people who want to malignancy. I'm not also the last one year. They do other points that need to be addressed in our malignant oncology. But there are very results of when
तुम्हें ऑडियो चाहिए तब
I was born. There are
कंटिन्यू करो डिस्कस
randomized findings.
वहाँ वीडियो क्या बस
वीडियो हमारे
And robotics.
टेलीविजन दिखाना ना
So I hope you understand my points.
South Indian culture, the ubiquitous is a human server.
He's waiting for a message.
ओके इस वाले को ना मैग्नीफाई वहां कराना है चलो पीआईपी पे ना हाफ लेना है वहां जो स्क्रीन है ना हाफ ये पिक्चर हाफ ये पिक्चर आप उसको बोलो इसका तो ये है कुछ और तो नहीं बोलना है I told the script, everything.
So, this right? हाँ, we have always developing technology.
Okay.
Okay, so we have got the passive bending, that's it, which for clinically easily आपको choose करना. Then 275 up, 275 down, logical scope. That. And we have also got the NBI
Okay.
to detect the upper urine.
What's the cost of the script?
Sorry, sir.
Cost of the scope.
Cost of scope. सर ये पूरे सेट के साथ आता है
नहीं इसके बगैर खाली
ये नहीं कंप्लीट सेट के साथ आता है सर ऑलमोस्ट 20-25 लाख अप्रॉक्स तो ये सेल्स पर्सन ही बता पाएगा आई एम फ्रॉम
हाँ इसको यूज कर
Dr. Raj,
मतलब ये
usual persons in the auditorium.
आपके बता ये बता कर दिया नहीं मैं में बंद करके निकल गए
Flush करो. Flush. Sir, what is on your monitor there? You have a vision of the CRM picture?
Yes, please.
No, no, actually, we want to show the CS. There was CRM. Can you start to magnify your PIP? Magnifying your PIP? The corner picture. Yeah, there is a PIP picture with you. You can magnify it. You tell the video people to magnify the PIP.
Left side is CM and right side is
So you see this and the CRM picture, the fluoroscopy is confirmed with this complete clearance. We have simply dusted the stone and this is how you do a RRSR. Will you put in the stand time? That is all from this OTO.
Okay.
Thank you, sir. Thank you so much, sir.
Can I make a comment for Dr. Shah's laparoscopic and robotic surgery comparing? There is like Dr. Senthil Nathan said, there's a international consensus group called Miami Guidelines now, and before that it was the pancreatic surgery group, and like nearly 660 papers right now. Out of those 270 papers, ultimately the guidelines came out. For distal pancreatectomy right now, if you have resources, it should be minimally invasive. Doesn't depend laparoscopic or robotic. If you have robot, better, because spleen preservation rate is higher in robot. It's easier because there's ambidextrous, so you can operate with your left hand, right hand, any angle, multiple degrees of freedom, and it is far more easier than the laparoscopic. But if you're skilled laparoscopically and you can do it comfortably, no need to change. But world is heading towards the robotics. Right now, 80% of surgeons in the world are doing minimally invasive distal pancreatectomy. 80%. Only 30% are doing minimally invasive robotic ripple, which includes robotic laparoscopic as robotic. But I'll show you the data tomorrow. Hopefully, you'll be able to talk how it is progressing towards a robotic. In next 10 years, most of the surgery will be robotic.
Oh.
And regarding the oncological outcomes, you know, in medicine, always we say non-inferiority. Now, nothing is superior. Right now, the most trials are showing the oncological outcomes, if not superior, or at least at par with the open surgery. Lymph node yield is better actually robotically, and the margin status is better. But if you are not well trained in robotic, you can actually hurt the patient in robotic ripple. But robotic distal pancreatectomy is a good procedure to start with your journey in the robotic surgery.
I think the discussion between whether we should do laparoscopy and robotic should be sometimes else, because we are this time witnessing a procedure in surgery. We should focus on the procedure
Section.
I'll show you tomorrow. Hopefully you're here. I'll show you what are the indications of open surgery in 2023.
Yeah,
You see, doctor, we are well aware with all international data. You see, understand what we are saying. We know what's happening right now in whole United States as well as in Japan, maybe in Pacific Islands, I don't know. As far as robotics is concerned, the major advantage, what we see in ripples, would be vascular anastomosis.
Vascular anastomosis?
Yes. It will be once you are resecting the vein or the artery, then the anastomosis will have an advantage on the robotic side. Understand what I'm saying? As far as robotics goes right now, this is a huge country and a poor country. Time constraints certainly are here, not in the United States. You have enough of funds, you have enough of OTs.
Retraction.
I think time is on your side, not on our side. If you have to finish up the case and you have a huge queue of patients waiting,
Zoom in.
we're going to die otherwise. Understand what I'm saying? Then you're going to miss the people not to operate. It doesn't close the case here. Understand? Finally, as you rightly said, robotics is going to rule, but that will be telerobotics, what you are talking. And The only advantage what we have with robotics as far as the laparoscopy is concerned, at present what we are talking, maybe tomorrow it will be different. Possibly the learning curve is easier in robotics than the laparoscopy. And manipulation, the tumor effect will not be there. That's what I said, the vascular anastomosis will be more fruitful than in open laparoscopic surgery. And as far as the tumor yield of nodes,
Zoom in.
these are all lymphatic tumors. Understand, the lymph node status is the main factor in majority of the cancers in that region. The tumor yield the ratio of what are the tumors are involved, and finally, I think it is settled. Tumor ratio, nodal ratio is one of the most important prognostic factors of survival. I don't bother whether I have a robotics or laparoscopic or open. What I am bothered about is my survival rate. Understand? The morbidity is still high with open. I don't think we have been able to control the open morbidity. Mortality, yes, certainly. It has come down because of multidisciplinary teams, the centralization of this procedure.
I mean,
Well taken point as there's the geographic distribution, and if you have masters like Dr. Senthilnathan, then it's the way he is doing it's an appropriate procedure, and still the open surgery remains to be a gold standard for all these patients, considering the oncological aspect of the disease, unless you have that kind of mastery on the laparoscopic and robotic.
I agree with your point 100%. This is not a localized disease. This pancreatic cancer is a systemic disease. Always understand it. Surgery is still a palliative operation here. We can say whatever we can say about Whipple. I do 100 Whipples a year. I do 2 a week. But that doesn't make it better. Ultimately, patient, what survives? We still have 15% 5-year survival only. And that has only gotten better because of the better chemotherapy. Not because Dr. Sheikh does it robotic. Somebody else does it upside down. It doesn't really matter. Ultimate answer is going to be immunotherapy. So regarding this thing, you said telerobotics. AI is going to be the next step, but it's going to be super expensive. In the United States, it is a lot of money.
Very, very big way. So AI is going to come in a big way.
But AI is going to be more for radiology and the medicine things. For surgery, no AI yet. Just patients will not trust me.
Certainly, I'll interrupt you here before we lose the thought.
Yes, sir.
Both of us. We are talking about pancreatic adenocarcinoma, what you are talking about.
Yeah.
Don't talk about ampullary.
No.
Understand what I said. I have a huge series from the region of India. Among the top ranked 5 series, individual series in India. I consider that point. I have crossed around 300 Whipples in my lifetime. In this region, I have a follow-up, which is dating back to almost 23 years. With me right now in my mobile, that's what I was looking for. I have follow-up patients are living for more than 15 years, but they are ampullary tumors.
Agree.
Yeah.
Understand what I said. Why that's happening, biological behavior, other things will come up futuristically. The only thing what you are saying correctly is pancreatic adenocarcinoma is a systemic disease. Absolutely correct. Because the nervous plexus there, Takahashi's or Wakashima's plexus is there. It disseminates into that.
I think you and me need to have a lunch together so we can talk about it.
Thank you, Robert. T1.
Yes,
Yes, please go ahead, sir.
sir, I have mobilized the kidney. As you can see, I can rotate it 360. This is the hilum.
Yes.
Cleared on all sides.
Can you go down, please?
Mic adjust karo yaar. Mic, can you adjust the mic, please? Mic, please adjust the mic.
You see, a legend is talking.
Hello.
You see,
can you hear me?
I think Dr.
It's a history speaking. He has been my teacher.
Definitely,
right?
definitely.
He has sheltered me here in 1990. Understand what is he talking about? I have mentioned it up. You will see in the literature. How did it come about? And I'll send you an article that time. What is talking is long-term Dr. Zagar, Professor Zagar. I have the longest living Whipple with me, 98-year-old. And
Yeah,
I think some of, I don't know whether my resident is here, someone who's 98-year-old, and I operated him at the age of 80. And beyond 80, very few people operate. But then age has to be defined in years or in physiological
Thanks for
or.
the audience here.
That's-
I was 19 old last week. A robotic Whipple before I came to India.
Yes.
So age is not an age anymore. Like all of us are getting better. Yeah, so let's change the conversation. We can have a talk later. But
Chair, about age not limiting
it's not an
perspective.
invitation.
Can we have some comments? The Mufti is eagerly waiting to give his details of procedure because I think he has mobilized the kidney completely now.
Doctor,
Yes, am I audible?
just hold for a second. Professor Zargi is saying something. Just Dr. Mufti.
Okay. Pleasure. Yeah.
Right.
Jazakallah khair.
Wonderful comments from Professor Zargal. Sir, Dr. Mufti, please go ahead. It's a wonderful dissection you are doing. It's a book picture in front of us. We can see all the structures, beautifully delineated, ureter, IBC, and renal vein. Please go ahead and enlighten us further.
Well, as you know, in partial nephrectomy, the basic principle is that you should have a fully mobilized kidney. Because unless you have a fully mobilized kidney, you won't be able to correctly address to the lesion. See, this is the tumor here. Can you see?
Yeah, wonderful. And
this is a lower pole tumor.
Very clear.
So if I have to excise it and then suture the bed, I should have ease of convenience and the proper positioning of the hands. So I have to position the kidney. That is why the kidney needs to be mobilized and mobilized completely on the hilum and have good control of the hilum, because you are not removing the kidney, you are just controlling the hilum. And see, we can go behind this here. Can you see the posterior is free? And we can even go on this side and hang it like this.
Yeah. Are you going to clamp the pedicle?
So you can we have to temporarily clamp the pedicle.
Right.
And then position the kidney to our convenience.
Yeah.
And the next step is to excise this lesion, close the bed, and declamp the hilum, and then come out.
Would you go for a frozen section there to confirm the margin?
Actually, this is an encapsulated thing. Usually we follow the capsule, and we can, in a solid tumor like this, we can clearly define between the normal renal tissue and this. And
Dr. Sheikh. Yeah, it is RCC, I suppose, is it?
yes.
Dr. Mufti, it's Dr. Sheikh here. I'm not a kidney surgeon, but a lot of my friends are kidney, and I always help them kidney tumors going to the duodenum. Dr. Gill, Indrajit Gill, is one of the guys who's from Ames, and ultimately is in the US right now with me. So I have a lot of cases. When you use the size criteria for these tumors, when you watch them and when you do a partial nephrectomy, because it seems like it's a pretty small tumor. So can we watch these tumors, or because a lot of these tumors may regress by themselves, or what's your size criteria to offer them surgery?
Well, this is a very good question. But I must say that there is a substantial percentage of small renal tumors which are being put on surveillance in the West. But the surveillance system in the West is very well defined and very well attended to. But in a place like Kashmir, where I have to operate a patient from Karna and then I have put him on surveillance, is very difficult because, as you know, 6 months he will be cut off from the hospital.
Sure.
So this strategy doesn't work here. And anything that comes out as enhancing tumor on CECT has to be removed, because that is ultimately the treatment for our kind of population who fail surveillance protocols. Even they do not come on follow-ups most of the times. So I do agree that as per the guidelines being adopted in the West, there are centers who follow surveillance system in the small lesions, and the controversy is only in the small lesions, not in the bigger lesions. But since our system of surveillance is not very well defined, it's not it's not, there is no outreach of the medical help to the remote areas, and the patient will hardly turn up, or he will. And the psyche here is that if somebody tells a patient that you have a tumor, it doesn't matter whether it's small or big. For him, it's a tumor. So if I happen to put him in a surveillance protocol, so he will definitely have a second look and insist on that the tumor should be removed.
Point well taken. Surgery. Thank you.
Thank you very much. Thanks.
Thing from Santhanathan is on to the pedicle, putting the hemologs over there. So can we just take some feedback from him where he has exactly reached and
Please, by all means.
discuss?
By all means, you can go to the other OT.
Thank you, sir. Can we connect to GEM Hospital?
So I think now.
Yeah, yeah. Is it? Yeah, sir. Please go ahead. So there was a debate going on between the laparoscopic, robotic, and open surgery, and it can be discussed, taken up later on. What we feel is that if you have mastered a procedure, you know the significance of lymphatics and the nodes, then the procedure you can do best and deliver rightly is the choice. As we are seeing you doing it very, very beautifully with very little time taken comparatively.
So, Dr. Santhanathan, you're taking the split artery right now?
Yeah.
Yeah. Yeah. Can you tell graduates here, how do you make sure that you are not around celiac artery or hepatic artery in prostate tumors?
Yeah, that's a very, very valid point that you mentioned. It's one of the most important points that you need to take and have in mind when you do this dissection. All
Exactly, date is taken.
this
Huh? What's it? Fish. Whatever. Benim kendime kırma. Yatmaz eşçiliği on bozum. Kendime kırma.
Very much valid point that you mentioned. You can absolutely hold up the market private as you can say.
Does the left gastric vein does it does left gastric vein
Let's change.
splenic or
Let's go to the ligation of splenic artery. Should I speak? Dr. Santhanathan. Splenic artery is a long branch. I don't think we confuse it with common hepatic. When do we confuse? I don't think so. In distal pancreatectomy, never. If you know celiac axis,
I mean,
unless there's an anomaly, understand.
if you have proximal tumors, my question was if you have proximal tumors and you really have to get the lymph node celiac artery can be confused.
You see, it is very simple for a hepatic surgeon or a hepatobiliary surgeon to palpate the vessel with his left index finger. You can straight away find out.
we are talking about laparoscopy here.
We're here on robotic surgery right now.
That's right. But then again, preoperatively you define it.
Yes.
On a CT, on an MRI.
So you,
And then
Yeah.
finally, what about you see, you have the Michael's classification. You have huge number of radiologists, huge number of data available in the world.
you have data when you
See the space where there is no space to identify where the splenic artery and the hepatic artery is. Just look at the field.
No. My chair, don't talk like you talk like a surgeon. Hey, don't talk like it. I told Dr. Swain one day.
I'm talking about the procedure. No, it's very difficult to differentiate whether this is the splenic artery or the hepatic artery.
The space is got to be 100%. Let me tell you one thing.
What we want to communicate is if it is a body tumor and if it is sitting over the midline, then
If
it
you are
need to be.
a robotic surgeon, you need to know how to do an intra ultrasound. Because
Yeah.
the robot you cannot feel.
Absolutely.
I'm just resident. Come on, other people. I know all of you guys are experts in your field, but this most of my points I'm raising is for the residents and the fellows. And I also tell all the time my fellows and residents. Fellows are like
ये दिन मैंने तो आया मैंने तो
unless you know this surgery inside out open, you cannot be a good robotic surgeon.
Definitely.
Because the anatomy is upside down. It is not easy to identify anything in a robotic ripple, for example. You need to master open ripple and open distal pancreatectomy. And when you start in the practice, all my fellows who do robotic, who do 50 cases of robotic ripples by they are done. I said, first year you cannot do robotic ripple in your practice. Do everything open, 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 because you need to be master of the anatomy. And when you're in the OR, there are proximal tumors. You can easily get my boss, Urogenic. He is the top surgeon in the liver transplant. Does live donors for cadaveric children's. And tomorrow I will show you the vascular reconstructions we do. And he was looping common hepatic artery. I saw him and he called me in the OR. Hey, I'm new to this. Come on. I said, you're around the common hepatic artery. So people can be confused. People at that level of experience. He has done 2,000 transplants. So people at that level can anatomy is upside down, and when you're learning, you're not used to it. So for the graduates here, always start with open. You need to have a sound open base on which you build your laparoscopic and robotic skills. And robotic makes it slightly easier than the laparoscopic. But if you don't have facilities, I trained in AIMS. So I know how lack of resources we have in India. So I know east or west both. So I appreciate that point. Also, sometimes we don't have availability. Even in America, we have 9 robots in my OR. 9 robots. Sometimes I cannot get a robot because everybody wants a robotic. In those cases, I do open surgery. So we need to have lunch together.
Yeah, very well taken point. I think Dr. Senthilnathan is now doing away with short guess because his decision is adding a splenectomy to the procedure. And over to Dr. Senthilnathan, can you just let us know that any comments on your end, any of the points you would like to clarify on your end?
पानी के पानी पानी चाहिए पानी एक टूल लाना इधर
Trying to highlight.
good boy
And now, this now, we get
देख लो खुशी अच्छा ये है ये मुझे कब सुन यार तू इस पे किसमें ये प्रो क्या में जाएगा ला भाई इंस्पिरेट करेगा मेरे को
quite quickly. So, just know, so this is the pancreas body and things from the retroperitoneum, which is what that needs to be done. We have sufficiently mobilized the body and build up the pancreas. What needs to be done is the identification, isolation of the splenic vein. We have only built the splenic artery so far. Next, we will be identifying the splenic vein and then doing the splenic vein injection. And after hello, anybody there?
Yes, sir. Sir,
Good morning.
sir, this is afternoon, sir.
Honor.
Small.
Okay. Assalamualaikum, everybody.
मजा तो
Dr. Ejaz here, you are doing a wonderful job. Yeah.
ना
Definitely more than that, yeah.
It's
More than 100
bigger and it demands an proper, full thickness excision.
Yes.
By your side when you are doing small tumors in stomach or colon. Is it so? No, no, pain. And you are dealing with small tumors, not this case.
This is what we were actually discussing prior to when you were planning it intragastric, that the size of gist can many a times be quite deceptive on its exterior appearance. And all gist have reduced regards that they are not to be taken as adenoma, because there is much more to come from immunohistochemistry and your mitotic index, and you have taken a good decision to take it into a proper formal resection.
So we have we have
Third of the case. Yes. Thank you. Then meeting never went along.
Where was the exact location? Right.
So we have
Yeah. Oh, more than happy, sir. There's a comment from Dr. Ahmad Javed Shah. Just wait for a while. Yes, please. Yeah.
Okay.
Dr. Sadiq, there's a comment from Dr. OJ Shah. He wants us to know that regarding this, what was the first question, sir? Yeah, how did you know pre-operative that did you go for any study?
Yes, sir. CT scan and diabetes.
But he wants to know tissue diagnosis.
Tissue diagnosis is not possible in a case. Because if the submucosal network is not penetrating the
Right. So what is the option with you?
He's giving an important point, I think, Professor Umar, that we need to take it with proper concepts of excising the gist.
Yep. Dr. Salim, be ready for the bombardment of questions.
No. He is doing a fantastic
He has
job.
answered all the questions.
Salim is a star.
Also here, sir.
He is S star. He is doing a fantastic job. I
You
have
have a discussion live, sir. Let us.
and I want to encourage him.
Yeah, that.
One. Number
He's doing
point
fantastic
is,
job.
Salim, we are in an area of endemicity of carcinoma stomach.
Yes.
I don't think any family or distant family of ours has not suffered from carcinoma stomach. My two family members suffered from carcinoma stomach. Okay, that's separate. Now, if you are getting this stromal tumor, this is all invasion of the radiology. In past, let's say 20 odd years, we have been able to enhance these diagnosis and get the immunohistochemistry and find out these tumors. Previously, we never knew. Now, if you preoperatively diagnose it as a stromal tumor and CT and MRI are not sufficient, clear, then you got to have an endo ultrasound. They are submucosal tumors, as you rightly said. Very right. You cannot have a biopsy deeper down, but endo ultrasonographic biopsy. Why didn't? Well, you have an endo ultrasound here. Okay. Yeah, we'd like to hear that. That would be fantastic.
Yes, Dr. Shaukar.
Morning, sir.
Actually, this network not in our West Georgia. It is not only the case, but it is. Our one is not down state for the remains. You have get around 1.10 in the From the almost 1 centimeter, but it has got the external extension. There is no point to So what is the distance from the cross and what they mentioned? So we try to do it out and now we are sitting on one top.
Jaypur's hut gaya hai.
That's right. So these are the questions you have.
It is on a convenient area and the stomach, and a staple resection could have been another option with proper this thing. But anyways, now he has a bigger area to repair and he's almost done with the procedure. And I think most of the procedures are almost near conclusion. Professor Mufti as well as Dr. Senthilnathan. So we come back with endo-ultrasound is a very important area which Dr. Saab has rightly pointed out in such patients, and that's the area which has to be picked up quite more than it is being used at present in the valley. So can
Dr. Salim, you are lucky to have Dr. Shaukat by your side.
yeah, can we go to either of the can we have there are some more comments on the same procedure from audience. Professor Magdumi wants to make a comment.
Wonderful job, my dear. You are doing a very good job, and just has been removed. I don't want because there's a long panel here where I feel very little bit in front of them. Very little, very, very small. Anyway, the questions about GISTs is this: every surgeon who doesn't have a diagnosis and is working on gastrointestinal tract, GIST is the utmost histological diagnosis which has come as a surprise to you, to the operating surgeon. But anyway, if you try your level best, if you can place a most tentative diagnosis on a GIST, you proceed well, but keep an option open that this may be even entered as a GIST. And you give a happy news to the patient that you are better off because I was operating for something else, but you are better off, you are just because one of the famous men who was working with me, and he is a friend of all of our colleagues, his GIST was found in a very big institute incidentally when everything was, and I felt nothing. But you are not at fault, nobody has felt, you have done a very good job and tried your level best to come to a conclusion of most probably GIST, and it has come true. Thank you very much. You are doing a wonderful job. Thank you.
Thank you, Dr. Salim. Either of the two OTs, whatever is the choice of viewers, we can move on to. I think Dr. Senthilnathan is almost completing his procedure. So can we go to GEM Hospital? Yeah. Okay. Good afternoon. Okay.
Thank you, Dr. Iqbal Sahab.
Actually, you were anticipating to do it with a intragastric procedure and pneumogastric. It's a good beginning and a good decision made.
Thank you. With your permission, can you move on to OT1 and see how Professor Mahmood is doing a partial nephrectomy? OT1, please.
Yes, OT1. Hello.
Yeah, Dr. Professor Mahmood, are you audible? Are you audible?
Yes, I can hear you, Professor Mubashir. Thank you for coming. Thank you.
My pleasure, sir. Can you tell us what's happening right now?
Well, we are mobilized the kidney all through. I showed the tumor at the lower pole around 2.5 centimeters exophytic. And this time, see, there is an additional accessory vessel to the upper pole, and we are trying to have control of that. And once you have that, then you will address the hilum and remove the tumor.
Okay, we'll definitely like to come back, especially once you're doing those resection.
Thank you so much.
The control, and we'll ask you questions about the time period you permit to have the vascular control while you are resecting. So,
well, the recommended is around 20 to 30 minutes.
20 to 30 minutes. Okay, good. So can we have some more comments from with Professor Mufti from the audiences, because I think the urological participation has to be there. Okay, I think you're doing it very excellently, and they all don't have many controversial points over here as compared to gastric gist and the distal pancreatectomy.
Yeah, it's obviously very clearly clean.
Clean,
All the
done,
structures
very
very clearly
nicely
delineated.
done.
Thank you very much. Thank you very much.
So we are going to back to the GEM team, and if they are we are audible to them, then we can take some feedbacks from them. Dr. Mubashir, would you like to interact or?
Professor Senthinathan, am I audible, sir? Can you connect the audio of the GEM hospital, please?
दूसरा ले लो.
हाँ सर. This is one. All the complaint of verification of no convenience into the mouth. Mixing of drugs for relax incremental for stop.
ये तो क्यों बस. ठीक ठीक.
And we look at the triangle back. We investigate by our so direct esophagus and there was right lower across lower just then for and
Yeah, can you share the radiology so that
this is the medium esophageal bag shows the severity appearance and that technician got first way and we are planning for laparoscopic myotrophic and operating surgery. Is doctor from the law, professor, ma'am.
Okay.
Hand over this mic to the professor. He can brief us about the case.
Hope Dr. Shaukat is around and he doesn't want to do a poem over there. So a one-stop correction of ecclesia. We would all love to see that. If you have some inputs from beginning of the procedure, kindly let us know. Yeah, till when you guys start with your details of procedure, can we move to GEM, please? Can you please add the audio to GEM because they are our guests who have joined across the state and they're doing a procedure for us. Hello? Yes, sir. Yeah. Right.
So the company is reducing of this very clear. And then you are going to complete the whole thing for the transfer. The all the movie from the show that it is transfer from the intro to the one. And here you will be doing that with the same.
Professor Santhinathan, sir, do you routinely after spleen preserving distal pancreatectomy, do you use a post-operative Doppler or ICG to check for the blood supply to the spleen? Do you routinely use it, or it's just your experience over the course of time that you don't need any objective measure to see that?
You always become very happy in bed. You do not get lot of activity. So in some cases, the very happy in getting parent can without going to we do not use reform of that unless we have a certificate down or body factor. We don't have the technology.
Okay, sir. Sir, what is your preference for the use of staplers? We have not reached that.
This is a very important one in me discussion. So, the statement cartridge taking use based upon the business. Now, the obvious question would be how to assess that the density on the mobile.
Yeah, true.
So, it completes how to get fields and to work well on some of the concerns as well. If you remember, we are using this actually using or a need for division of the country, because very soft country might have to use the right step. So maybe 2.1, 2.8, 10.1. So depending on the need. And in this case, we are using the zoom camera on the say mind that we know this, that all the point we what we call as various compression technique. There is a beautiful variant of sorry. But we have created so variant of compression technique when we do the pancreas. What is basically, of course, we do not have level 1 evidence or argument to say that this prevents the risk of post-operative cancer and pancreas. But a graded compression technique, at least in our document, has shown to reduce the incidence of post-operative pancreas and water species regarding social biology in one. So what we do is once we fire, once we insert the stapler, not the stapler in 1 minute. So it is 30 seconds, 30 seconds, 30 seconds. Lower gaps, 30 seconds, like a lower gradual, really compression on the pancreatic paras advance. And only then you would not fire. So this is a great compression table which I want to mention in this thing.
So, Dr. Santhinathan, why did you choose the Ethicon stapler, not a Medtronic stapler or a robotic stapler?
The most of ones are actually not meant to robotic stapler with us, so the stapler thousands plan for recycling the books, one. Between 85 and because maybe I have just my personally. That is the one would be
Because like a lot of people like to do robotic staplers. I use robotic staplers, but then there are my colleagues. Then there are my colleagues who like to use the like you do bedside technique, and they prefer Medtronic stapler more over the Echelon stapler because it allows you to do graded compression, like you said. And Ethicon stapler is more brute, like mostly automatic right now, and fires through it. But as you
This is not a power stapler. This is a manual.
Oh, this is the manual stapler. Okay. Well, as you said, most of these things don't matter really ultimately because there is no level 1 evidence which protects it. We did all these things. We used to wrap it with the bladder mucosa, big bladder mucosa, meshes and everything. And we used to also reinforce the stapler. Ultimately, the leak rates were same. And I personally right now use for the ease use a robotic stapler because you can fire it yourself. And it has like a 60-degree angle, so it's more easy in a difficult situations. But excellent job, thank you.
What is your present robotic fistula rate, Dr. Santhinathan? And do you do anything beyond this graded compression and disconnection, like a hemo patch coverage or some momental wrap or something?
Dr. Shah has a question here.
Yeah.
Yes, sir.
Yeah.
Yeah. In the meantime, can you go to OT2?
That's what I said. It does not matter. I mean, ultimately, you have to understand that, like, if it is like a grade C fistula, for example, a bad fistula, that's a bad technique. That you didn't know how to compress the state.
OT2, please.
Because a lot of time, I'll just cut it also. I'll just use a knife knife and cut it. And then I'll use a stitch. But a robotic allows you to stitch properly. You can put a stitch which pledgets. Yeah. Yeah. So robotic is like 10x magnification. So you can visualize every detail well. Swishing is so easy. So it's like you're like this, you're like wrists. Friction rate with robot with better experience will come down, but there's a learning curve right now because people are learning. Like when I started in Whipples, I had double the leak rate as open. I was like, what I'm doing wrong? It was nothing I'm doing wrong. I'm just learning the technique. With time, I think the direction with the robot is the leak rate will come down, number one, and oncologically outcomes will be more superior. Like you earlier mentioned, that it has a role in the vascular anastomosis because vision is 10x. It's like operating like microscope, and I'm so close to anatomy like this. Now I don't like laparoscopic surgery because I am so used to seeing things so close, and no shaking of the system, no autofocus. All those things are not in laparoscopy. And then I have to constantly yell at my assistant, don't move the camera, clean the camera. Here, everything happens automatically. So you get spoiled, you get spoiled.
I yeah. Mean
In the meantime, can we go to OT2?
They are discussing. They have a
So open the hiatus.
procedure over there. It will get over. Yeah.
Ravindran? Yeah. Yeah, Dr. Mubashir here. I see you have opened the hiatus. Can you just tell us when you have reached?
Future. So we have to all agree.
Lot of open pancreatic resections. We have that liberty of looking into the duct, the smallest one, and closing it with a non-absorbable suture.
Yeah,
That's what he wants to make a point.
but-
It has to come more clear in your robotics and laparoscopic. With lot of experience, we have very little.
Also,
to
though, you have to understand,
So it all
even
depends
if you
on
use
the
microscope,
and-
your vision is not more than
and
3.5x.
what they are into a procedure which is relatively short in origin, and we will have to give them due because they have come all the way operating on eclasia cardia, and they would be doing an incision. It would be done. So we are there with you, Professor Lal. Can we have some inputs from you? Yeah, so where exactly you are, and when are you planning to give an incision? And what are your further plans for your plications, and or you're just going to do what were your manometric studies in this patient? Any associated
You asked too many questions.
yeah, any associated problems over there? Because we got disconnected very early with a very brief history and a monogram.
Yeah, so I have mobilized and I divided the peritoneum on the right side in the right throat and the elevator went saw the anterior region there. I'm trying to go behind the puppet which I showed and I divided peritoneum to the left side with the division of the gastro pleural extension here. Important divisions now been paid, and now I have been consolidated chain on a testimony. So we just want the instructors structure. You can see the diameter innovator is there.
Yes.
And possibly mega innovator in the opinion, so this is this will be constricted, so you can leave that. And we will be
Doing that division, once we have reached that level, I'll be there in a few minutes. So these are the initial steps which we do for any kind of fundamentalization of change for everybody, especially training level who are there. Can see the depth of mobilization. Now the important division that I do not do a distance, I do a mobility modifications. That's one difference. Second difference between the three, I do not make a large opening. I have kept the bigger branches. These are the bigger.
Yeah.
The rivers, I do divide them under certain stored tubes. So people usually divide from the part Canada across here. I try to make a smaller window. And so my method is taking the ethophagous is using a corrugated plane, small pieces of corrugated plane. To my mind, this causing these trauma to the ethophagous when it's
With this, we come to the end of this session number 2 today. I thank all the chairpersons for their valuable time. I request Professor Shaukat Jilani sir to come on the dais and felicitate our chairpersons. Professor Sadapali, please. Sir Eja Ahmad Reza sir. Professor Mubashir sir. Dr. Shakib and Dr. Rashid, I think he has left. Dr. Rashid is here. Dr. Rashid Sheikh. Sir, one more chairperson needs to be felicitated, sir. Dr. Rashid is coming. Sir, thank you all. We are going to start the third session for day 2. I request Professor Shaukat Jilani sir to chair the sessions. Professor Arif Hamid, Professor Urology, Sri Kashmir Medical Sciences. Dr. Akhtar Ganai, Consultant JLM Hospital. Good morning, everybody. Dr. Mohammad Yunus, Consultant Surgical Gastroenterology, Sri Kashmir Medical Sciences. Dr. Abid Hussain, Consultant General Surgery, GMC Baramulla. Over to the chairpersons. Hello, good morning, sir. Dr. Umar. जी डॉक्टर साहब सलाम डॉक्टर साहब ठीक है वालेकुम सलाम सर आप ठीक है सर जी सर
जी डॉक्टर साहब. And actually, the audience can feel the transformation of the Department of General and Minimal Access Surgery in GMC Srinagar. And our seniors who are here and all of us are proud of the performance of this department, its growth, exponential growth, and with the technical departments of other departments. And wonderful work is being done by the Department of Surgery in Government Medical College, Srinagar. And I must- Yeah, that's right. In the ultimate, there's a team there with everybody and everybody is together hand in hand and the government is taking steps to this level. And this is going on. Yeah. We can continue going more and more at the same time. And yes, we take a cue from this. And the ultimate famously to ensure that this department is one of the best departments in the country and possibly in the world. I must congratulate Dr. Mufti and Dr. Iqbal and the members of the Department of Surgery for their hard work. You really deserve an applause. Dr. We are connected to Dr. Iqbal. जी डॉक्टर प्लीज कंटिन्यू. बात करो भाई. बात Yeah.
Dr. Iqbal, are you using introp endoscopy in this procedure to localize what is the location of the stomach? Okay. Okay, good.
Will you remove this tumor, Dr. Iqbal?
OT3?
Yeah, OT1, OT1, huh?
OT3? OT2?
Dr. Iqbal. Hello. Hello. Hello.
Iqbal sir.
Hello. Dr. Iqbal.
Can we get connected to OT1, please? Hello.
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 Professor Mufti.
Yes.
Yeah, Dr. Arif here.
Welcome, sir. Welcome.
You're doing a wonderful job. Partial nephrectomy. So,
Thank you very much.
yeah, I just have a query. Do you use those bulldogs sometimes instead of a common clamp?
Yeah. When you have multiple vessels, then we tend to use bulldogs.
Bulldogs.
Since this was a hilum was more or less vein and artery were close to each other.
Yeah.
So we preferred to use a clamp, but there was an additional vessel in the upper pole. So to that, we have clamped it separately with a sling.
Okay. And are you sure that it has not gone into the PCS?
You can see that the PCS is not visible at all, and more or less as per the CT and findings, the very superficial tumor, more of exophytic, 2/3 was exophytic only.
Okay. Do you use a DJ stent ever?
We actually put in a ureteric catheter initially. If we suspect that we are going close to the PCS and we might breach the PCS, so we keep a ureteric catheter. Now that helps in two ways. One is that we are able to check any extravasation or any breach into the PCS during the surgery. And second is that it serves as a drainage.
Yes. Yeah, there's a question from the audience.
Dr. Mukdimi Shah. Before Dr. Mukdimi Shah, Dr. Mukti Shah, अस्सलाम वालेकुम.
वालेकुम सलाम.
मैं डॉक्टर शफकत बोल रहा हूँ.
जी.
मुझे आपसे ये पूछना है, I had to ask this question from you. Do you ever need to use a section biopsy to ensure that the margins are adequate and there's no possible residual tumor in the area?
Actually, these tumors, they are encapsulated tumors usually. And once we excise them, we go close to the tumor and we get the feeling that we are have removed the solid element of the tumor along with its capsule. But at times when you are not sure about the tumor bed, you can go for force resection. We have facilities for force resection available now in SMHS.
What is the normal safe margin do you leave the tumor with normal tissue of the kidney?
Yeah, we remove it around the tumor around half a centimeter of the so half to 1 centimeter around the margin, and the depth is perceived by us as guided by us by the capsule of the tumor, because the consistency that we feel is different and the look is different on camera as compared to the normal renal tissue. So we can safely differentiate between the two.
Actually, this is very well. And I must congratulate you, because you know there were times when there was a tumor in the kidney, the treatment was radical nephrectomy. Now it is all underwent a radical change, and that radical change mainly has been brought to many urology in these tumors that we should look to. And I must congratulate you for that. Try that nice, and it's a very great job done and successfully so. Now, Dr. Mukul Sahab has a question for you.
Can we connect to OT2?
Okay, Dr.
OT2? OT2. Sir, I'm Dr. Yunus from Auditorium. I want to ask how much do you mobilize the esophagus, lower esophagus? How much centimeters? Do you go beyond this crust in the chest? Sir, another question. What are the precautions you take so that mucosa is not injured there? What are the energy source you use? I have seen you have used it first harmonic and the active blade was not covered. How are you sure we are in the intermuscular plane? What is the Yeah, no.
And every two guys reform and factor all together becoming completely that field, and then you see the you're gonna start popping out. I will
Yeah. Do you use cautery sometimes?
no swimming line should be low and concentrated seat really. It's very easily key from the as it is expected not know now. So try not to use. And you can see on here the circular guidance, you can see in the different number of circular guidance. See that?
Yeah, yeah.
The circular guidance are very easily there. Now you will have eager you describe. Can you just see that?
Yeah, yeah. Yeah, yeah. Yeah.
I really never want to just say on this problem.
What are the your tips and tricks for juniors for your juniors to prevent injury there?
I can go with you. You very clear about the ranking which I realized, but you tell me the piece of the sorry, I got the entire aggregate of the keys or all keys. And I mean,
Do we need to identify the vagi?
sorry.
Do you need to identify the vagus first?
No, I give the very like
How to identify that vagi anterior?
we have very about mentioned the three in the trial.
Do you need to go to look for the vagus or it can be left there?
Well, normally you don't because
That is not clamped.
That's the reason. No, it's just
Shut up. इसके साथ नहीं छेड़ना
जी प्रोफेसर इकबाल वालेकुम अस्सलाम
someone not understanding that, but we can do that study. Right? Good. That's good. and fire is carrying this problem. Skin is kind of very kind, energy and now well, I will find so much.
It was excellent, sir. It was excellent and it was a treat to watch. Thank you very much.
OT2. Something about pre-op evaluation. What did you, sir, do routinely for these? Yeah.
Any comment, any question from the audience, please?
Sir, OT2. What is it? If some patients come for after number of sessions of pneumatic failed pneumatic dilatations. Is there any difference in that area when you operate, when you go in? So, are there more chance of mucosal injury in those patients, and how do you prevent them?
चलो चलो पीछे आ जा पीछे आ जाना एक मिनट रिलैक्स रिलैक्स डोंट वरी हॉट हॉट
Can you connect to OT1, please?
OT1.
OT1, please.
Hello.
Yeah.
Yes.
Yes, Sir Mahmood.
Yes, Dr. Arif.
Yeah. I think you are through with closing the defect.
Well, we had one radiography of the bed, and now we are trying to approximate this.
What is the ischemia time by now?
It is around 10 minutes have gone.
Okay.
Good afternoon, Professor Mahmood, sir. Dr. Abid from GMC Baramula.
Good afternoon, dear. How are you?
Sir, how are you? Fine, sir. Alhamdulillah. Sir, you are doing a very wonderful job. There is very nice hemostasis we can see, and you have removed the tumor basically. So, what about placement of a drain, sir? You will place a drain or no?
Yes, we will place a drain.
Okay, sir.
From that point of view, I am a conservative surgeon.
Okay, sir. Okay.
OT2.
Then how do you know the grade of tumor in
OT2? Sir, if God forbid there is a sometimes mucosal injury, how will you identify that? If sometime there is a mucosal injury, how can we identify that? Hmm.
डॉक्टर मैं आपसे पूछ रहा हूँ आज
Is there any leak test you perform?
Dr. Adil, how many times before surgery do you require a biopsy of a kidney tumor, particularly those who have to undergo partial nephrectomy? And how important is the biopsy in these situations?
Good question from Professor Shaukat. Basically, all the these lesions are to be taken as malignant unless proved otherwise. But there are certain situations where you need a pre-op biopsy. One is that what we call as radiologically indeterminate lesions. But nowadays, it's not a term because radiology has improved a lot. Second is if it's a tumor in a single functioning kidney. So we want to be reasonably sure. Or you have multiple tumor. You are suspecting a secondary into the kidney, or there is a doubt of a lymphoma. So these are few indications of getting a preoperative biopsy. Otherwise, all you have to take as malignant, whether you are doing a partial or radical, that depends on the situation. You have to go ahead with the excision on there.
The benefits of laparoscopy in the situations in partial nephrectomy. Is it advantageous over open?
It is advantageous because all the advantages of laparoscopy over open for any procedure as such, the visibility, the magnification is as important. I think better than in open. So it's always an advantage. Yes. But there's a learning curve. Yes.
Hello.
Professor Mahmood.
Yes.
Yeah, you are releasing the clamp now?
Yes, sir.
Yeah, yeah. Yes, is it? You are releasing the clamp.
Yes, we have released it, just placed it there, but it is released.
Yeah. Just released, you are not removing.
We have released but not removed.
Yeah, yeah, yeah. You have to see the hemostasis.
That's right.
ठीक है ठीक है release sometimes you have to reapply. Professor Mahmood, have you ever reapplied the clamp? What is your experience in such a situation?
Yes, in one of the cases I had to, there was an arterial bleed which was coming through the suture line.
Yeah.
And initially we tried to suture it while bleeding. But then we had to, because we are in the habit of not removing the clamp as long as we are not certain that the hemostasis is perfect. Because realigning the clamps is difficult and leads to a lot of handling of the kidney.
How did that kidney behave? I mean, the concept of a reperfusion injury and all that.
Actually, that was a small tumor, and I think warm ischemia time was around 12 minutes.
Okay.
So there was no issue with regards to the vascularity or.
Okay.
Yeah.
Right. Do you ever mark the tumor, these lines before applying the clamp? You sort of mark the tumor all around. Do you use?
Yes, sometimes we use a hook cautery.
Yeah.
To delineate the margins when actually when the exophytic component is not very prominent itself.
Yes.
So in that case, we need to chalk out the area of resection.
Yes. And what is your experience, sir, about smaller tumors in the hilar area?
Hilar areas, as you know, that's a red area to go in.
Yeah.
You need to be, I personally believe that you should have adequate experience as a laparoscopic surgeon who performs partial nephrectomies and who has adequate control over his left hand, right hand, then only he should try to attempt central tumors.
Would you contemplate an open procedure in that situation?
Why not? There is no harm. There is no harm.
Yes.
Ultimately, it is the patient's safety and patient survival that's important.
Yes. Professor Salim Wani from audience has a question.
Dr. Mahmood, good morning. And there is no question actually. I want to compliment you for doing a wonderful procedure and flawlessly being done. And you need word of applause for that. And doing laparoscopic surgery, especially partial nephrectomy, and when the tumor is medially and where you have been working around the vessels, is a great job. And I really compliment you for doing this procedure so flawlessly.
Thank you very much.
Well, for the question of how do we delineate the tumor, the endovascular ultrasound would be
that's a good option. That's a good option.
option to know about the procedure. And recently we did, and we had bilateral tumors where we had to do. It was in fact it was the second case in the Sher Kashmir Institute of Medical Sciences, where we had bilateral tumors, and in one of the sides we had to do partial nephrectomy, and then second side we did after 2 months, and we had to do the bench surgery. We had to take this kidney out and preserve it in the ice, and then did the bench surgery to remove the tumor, and then did the auto transplantation, and we transplanted it into the right iliac fossa. So those are the situations where we need to at times change these things, but there again, the ultrasound helped us in delineating the tumor which was medially placed. Good job.
Absolutely, I agree that ultrasound is a very vital tool for such lesions. But I also am of the opinion that these surgeries, partial nephrectomies and solitary kidneys, one should venture into these when you have created the perfect team. Team means that your cameraman should be absolutely know of the things. Your assistant should be your other assistants. The team has to be there, and then only one should venture into more of these cases. And while I'm being complimented for doing this surgery, but I'm thankful and I'm indebted to the team that I have been able to create, who are doing a wonderful job in delivering cases of advanced laparoscopic urology.
Yes. Professor Mahmood, I have one more question, sort of a query. In your experience, did you ever enter a post-operative resection margin positive?
Not to my knowledge as yet, but there was one. See, there is still not an acceptability among our medical fraternity into venturing for partial nephrectomies.
Yeah.
So we happened to do one of the cases, I think last year, January 2022. Small lesion in the upper pole, and once we did it, the biopsy tumor was free, and there was absolutely no issue. Perinephric fat was not infiltrated. So he happened to meet a local medical practitioner very skeptical about undertaking partial nephrectomy, and he was convinced to do a this patient was very smart, so he went to Delhi and went to a couple of places, which included AIMS, Gangaram, and Medanta. And he was told that Ajay Sharma also, Ajay Sharma and all others, they convinced him that the procedure has been properly designed and executed, and we will not go for ablative procedure. He's still under our follow-up doing well. But the message is that we need to understand that this is an era of renal salvation.
Yeah.
There was a time when I was a student when nephrectomies open, lying right and left, irrespective of the size of the tumor, location of the tumor. But as you well know, acknowledged transplant surgeon, to understand the elements of renal tissue. And as residents of urology and renal transplantation, we need to make our colleagues and the community at large.
That's why Dr. Professor Mahmood, the term partial nephrectomy in urology setup is now being replaced by nephron sparing surgery.
Absolutely, absolutely.
Always NSS.
Absolutely.
Then partial is a vague term.
That's right, that's right.
But itself conveys everything that you want to spare the rest of the nephrons.
True, true, true.
On the chair. Regarding the nephron sparing surgery now in vogue, there was a time when we would do extended radical nephrectomy, then came the radical nephrectomy, then came partial nephrectomy and lymph node dissections, hilar lymph node dissections. Regarding the acceptability of this procedure, well, it is acceptable procedure now. I have one of the leading medical oncologists who happened to get diagnosed as the RCC, and he was amenable for the nephron sparing surgery, but he refused. It is just some 5 years back. He refused. He said that no, kindly do the radical nephrectomy. We had to do the radical nephrectomy. Regarding the margin positivity, well, we have to be sure that we have taken, previously there was 1 centimeter, now there are 1 or 2 cells only. I am yet to see a case of recurrence and margin positivity. We had a case that was done outside, and he came with unfortunately the things now is in the market is the PET scan, and the people and the patients think that the PET scan is a treatment. And they come with the PET scan for everything. And he had gone for the PET scan. There are reasons for going into the PET scan, and let's not go into the details. So the patient had got for a PET scan, and the PET scan showed that there is some activity around. And we followed that patient, and I think it is now 4 years. There was no. I want to stress upon that there are set protocols for the follow-up of these patients of radical nephrectomy or nephron sparing surgery in post-operative period. And I think those are the things which we need to inculcate in our juniors and tell them that the protocols which are the guidelines of the AUA and EUA should be followed strictly.
OT2. OT2.
Hello, can you connect to OT2, please? Hello, OT2.
Sir, I want to ask how much circumference of the mucosa you denuded you are exposing. What is recommended? How much should be exposed? So, yeah, 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 yeah. Yeah, yeah. So do you use do after this procedure fundoplex in every patient? Yeah, yeah. Do you apply stitches to the lateral pillars which are formed for eversion and
With the permission of chairperson, can I ask a question? Hello, Lal sir. Sir, what is the proximal extent of myotomy? Yes, sir. That's why I'm asking that. Yes, sir. Distal myotomy, which is more important, or proximal, because distally we need to extend to cardia. If we don't extend to cardia, it leads to failure. And sir, what is your preference of fundoplication? You do topias or DOR? Thank you, sir.
Any comment from the audience also? Dr. Avan, Professor Avan, Professor Shakil, and Nazi, Dr. Saldru, and
Can we connect to OT1, please? Professor Mukti Saab, are we audible?
Yes.
Sir, we think you are about to complete your procedure. So there's one question. Do you put pre-op or intra-op stents in these patients?
Well, I answered that question. During pre-op, we put in a ureteric catheter.
Okay, sir.
And it has a twofold advantage. One is that during surgery, we are able to delineate any possible breach in the PCOS. And second is that it serves as a drainage post-operatively.
Right, sir. Thank you.
actually Dr. Mukti does deserve an applause from the audience, does he not? How common is this eclasia cardiac errors in Kashmir, Dr. Rao?
Basically, these cases are not there. We have a but it's not shown properly. There is a lot of disparity. The people, the general patients are not. They don't know the entity, and it is not being diagnosed properly. There is diagnostic armamentarium is not available. We don't have. We still don't have manometry here, and all those gadgets. So it is not being diagnosed properly.
So, for this patient has been diagnosed from this place.
I don't know about this patient, but one patient in this tertiary care center you can get easily. But overall, I can say it is not having too much incidence here because, as I said, the patients we don't get so much of patients. There are very less patients.
No, but the incidence of this eclasia cardia in adults is less in Kashmir.
There can be a number of reasons, but we don't see in our OPDs much patients of this eclasia cardia.
Dr. Avan, etc. How often, how common is this eclasia cardia in Kashmir? Equals, huh? It's very common. They say how the patients with compulsory. Manometry also. Is it essential to have mandatory strategy? The short of a basic breakers.
Just a moment. No, because we are finished. We are prepared for inauguration now, after Nimos. Go for Nimos and then prepare for
We missed, and there are people that
Which can come.
so the non-availability of the manometry and
We are done. If we are done, we are coming in.
because that's the reason why we have less number of cases here. But the incidence is quite because we are missing these cases. That's a message we want to convey.
So how to work what should be done?
Basically, we don't have a manometry, HRM, which is the gold standard for diagnosing these cases. Unless you don't have an HRM, you cannot diagnose them, you cannot prognosticate them. HRM is the gold standard. You classify them as type 1, 2, 3 and prognosticate and accordingly take them for surgery.
This message must be conveyed to the administration also that they are forgetting and scientific calculation of the this place and for want of a very small instrument called also manometry.
In skims, the
With permission, as Dr. Arshad told, because of the not proper diagnosis, these patients go for fundoplication. So that adds to the misery of the patient. So we should diagnose the primary and then
that's what I'm telling. the administration must wake up. Now, in this important investigation.
Seven skill Department of Chairpersons. Sir, I welcome Professor Mohan Singh Shah, the stalwart of our department, who have just joined us. It's really nice to see him again, hale and hearty. I hope he enjoys where his department has reached. Thank you, sir. Thank you for coming.
Sir, regarding manometry, the Department of Gastroenterology schemes have recently started doing high resolution manometry. They are doing now quite far from quite few months. So they have started. They have got the equipment there. So it is a message they can send the patients there for. Actually, these patients, the patients of achalasia, they need first workup should be done properly. At least minimum high resolution manometry should be done because these patients, if not diagnosed properly, they can then secondly they can get aggravation of that problem. So high resolution manometry is a gold standard before taking the patient for surgery. Not only barium and all that, at least high resolution manometry should be done.
Actually, it has to be 4 investigations which we need to do in these patients.
Yeah, barium.
First is an endoscopy,
Barium.
CM, pH studies, and then HRM. To confirm, it has to be an HRM.
And that will also help you to identify clear case of GERD and also differentiate it from cachexia.
Yes, sir. That's most important.
That is the role of pH manometry comes in. The patient of reflux and the GERD symptoms should have both investigations like high resolution manometry and pH monitoring. When we do the skims, Department of Gastroenterology has started 24-hour pH monitoring. So they do it now, especially in case of GERD. We are doing now. We have started. Many departments have started fundoplication procedures, and for that, the history alone is not sufficient. They need to be investigated thoroughly because when we in a flux that who doesn't respond to the medicine, most of the surgeons they take and go for fundoplication. But that can aggravate the problem when with the fundoplication they can get that led to dysphagia. Some patients have some other motility problems other than this reflux. So 24-hour pH manometry is the gold standard for for taking the patients for any reflux surgery like fundoplication because to prevent the post-op complications and to augment the diagnosis. So it is a message pH manometry should be done